So now we want to kind of talk about, when we see patients and we look at the PSA response. I know we have some of these newer studies that are enrolling called the Triplet study, where you patients start with an ARPI, ADT versus ARPI, ADT with chemotherapy. And so, but then it asks us the question, what is our goal whenever we start patients with metastatic hormone-sensitive prostate cancer? Is it to delay castrate resistance? Is it to get that PSA less than 0.2, which is considered low? Or is it ultra-sensitive, which is 0.05 or 0.02? What is your goal, Vikas, whenever you start patients on triplet therapy or doublet therapy?
My main goal is palliation. So if someone has stage 4 any kind of cancer, we know it's not a curable condition. So if someone is symptomatic, main goal is to control their symptoms. And then if there is a survival benefit, definitely I try to go for that. These ultra-low PSA, these are academic discussions. It does not really matter to me when I'm making a clinical decision. But it's good that certain medications, certain ARPIs like Erleada and Xtandi and darolutamide they achieve faster and deeper PSA response. But when I'm making a treatment decision in the beginning, it doesn't play as big a role.
Yeah, great point. And I think this is where the studies are moving. And Ryan and we kind of talked about these patients that are hormone sensitive, low volume, PSAs less than 0.2 for many, many months. So can we de-escalate? That's where the studies are going right now. So what are your thoughts when you see these patients of maybe de-escalating or maybe giving them a treatment holiday in these low-risk metastatic hormone-sensitive prostate cancer?
Well, a lot of it is patient tolerance and their buy-in.
Yes.
So I think, it's an individualized decision when they're sitting in front of you, and, giving them some say in their care, I think is really important. And I think they buy into the therapy more, knowing that they have some control over how they're managing their disease. But I think you have to, be completely transparent that this is a holiday.
Right.
This is unlikely to be permanent, and the time will come where we need to resume it.
Absolutely. Now what I'm going to do with a little quick thought exercise. It's going to be interesting. I want to see what the panel thinks here. We're going to have the Capitello study coming out with the P10. The news flash is already out. We're just waiting for the paper to come out. We're waiting for the presentation where P10 with the AKT pathway for metastatic hormone-sensitive prostate cancer, whispers of PSMA upfront, upfront PSMA, but PSMA, where you do the hormone-sensitive. That's going to be coming out at ESMO, right, when you have Pluvicto with dealer's choice. And then you also have the amplitude study. So you can foresee in the future where in the metastatic hormone sensitive, it's going to be biomarker-driven, right? Mm-hmm. And where if a patient has a PSMA PET scan and the average PSMA mean is like above 40, maybe they should consider PSMA Pluvicto with AR pathway inhibitor. Maybe if they have a P10 mutation. Maybe if they have a BRCA2 mutation, because BRCA1 I'm not really sold on. What are your thoughts, Travis, on this, on the future landscape of metastatic hormone sensitive, how it's going to be biomarker driven like in the next 6 months or a year? What are your thoughts?
I think it's welcomed. I think in the castrate sensitive space, we don't really have a lot to go on right now.
Yes.
There's a little bit of prognostic factors in the castrate resistant setting. Some of those HRR mutations mean a little bit more in that space. FDG PET avidity means more in that space. There's a lot of things that guide decision-making at that standpoint. And then like when Ryan sees patients in a localized setting, Decipher scores and genomic testing in that setting makes a lot of sense. But in a castrate-sensitive setting, with the exception of volume and their PSA and doubling time, we don't have a lot. I think this idea about sort of de-escalation with achievement of PSA ultra low, yes, is compelling and interesting, but we're not quite there yet in our ability to sort of change treatments that have already started or de-escalate or escalate once we've started at this current time.
Absolutely. Now Zin, whenever you have a patient, and for anybody else, but like you start thinking about this journey, right? If you do a certain treatment, you're going down this road. And so let's say if you have a patient, you're considering triplet and doublet. If you do a doublet, right now you could consider Pluvicto because we had that updated with pre-taxane with Pluvicto, but you also consider docetaxel there on AR pathway inhibitor with ADT. Do you think about the future treatments when you decide triplet versus doublet when you first start?
Yes, and also the aggressiveness of the disease, right? So triplet therapy, even though the comparison is with the ADT plus docetaxel, so we don't know with the hormone therapy control which one, adding docetaxel definitely prolong OS, we don't know. However, like with that, the decipher testing, if they have a high decipher, even if they have a low volume or high volume, docetaxel seems to have a benefit. And if they have a spot mutation, like hormone therapy, definitely it's better. So I think kind of, we need to have all the informations and then kind of decide about, should we add docetaxel? Every patient, we know all low volume or high volume, they will benefit with the doublet hormone intensification. However, adding docetaxel or adding PTEN inhibitor or PSMA or all these kind of, we need more data, and then we need biomarkers and to decide about which patient need to be aggressive and then treat triplet. And of course, like the sequencing is also very important, and which we still don't know. Like the best sequencings. I think the sequencing also kind of depend on the disease progression, like what's the location. If they have a visceral disease, then I tend to go with the docetaxel. If they had a doublet up front, then tend to go with the docetaxel chemotherapy, and we can also go with the Pluvicto. I don't think we know which one is better, Pluvicto or the docetaxel. However, we know the second line hormone therapy is, the Pluvicto is better than, or the chemotherapy even better than the second line hormone therapy.
Yes, great points. And that's some of the things we have to think about. We have in a castrate-resistant space, we've got the therapy study and we have the CARD study. But in those patients that benefited, it was like in the CARD study, the patients that benefited with chemo are the patients that progressed less than 12 months. And then on the therapy in the castrate-resistant, it's the ones with the mean SUV PSMA above 10. Okay. So can we extrapolate that? But that's going to be interesting. So any lasting thoughts, any pearls for anybody on the hormone-sensitive space?
I'll just tell you that, like, as we are moving a lot of the therapy up front, I think we should still focus on overall survival, right? So moving up this, obviously, will add financial toxicity, but if we are not pushing the overall survival, right? So, it will be good to see overall survival as we moving this combination, new drug, up front, that we are actually pushing the boundary of overall survival, not just radiographic progression free or ultra low PSA. But these are good, as Vikas said, for discussion academic. Sure. For patient's sake, we do want to push that boundary of overall survival. So overall survival, and I think everyone agrees, is still the gold standard benchmark for any combination or new treatment.
Yeah, great points. Any other thoughts or overall survival? And I think the other thing is, the one thing that we all want to know is if they have a BRCA2 mutation. Because if they do, we're at 22 months versus 41 months right off the bat. And that's the prognostic factor of BRCA2, even though with medications.